Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be discussing on one of the very interesting topic which you see very commonly almost in everyday practice, that is edema. The person will come to you with swelling in the lower limb, most common way of presentation. So we'll be discussing from that point of view. So we'll come across lot of different people. So this is edema. Here you can see there is a difference between the two limbs. There is a swelling here. There is a swelling of the face, lips, eyelids. Only one side, lower eyelids, is more swollen. You can see this limb is also showing swelling. All these are edema. But each condition is different. The treatment is different. You should be able to identify what is the cause of swelling, where is the swelling, and why there is a swelling. And then depending upon the diagnosis, the treatment will change. So that is what we call as approach to edema. So what is edema? Edema is defined as a palpable swelling caused by an increase in interstitial fluid volume, or we call as an extracellular fluid volume. So edema is a clinical condition characterized by accumulation of excess of, some people also use the word abnormal excess accumulation of interstitial fluid, and can either be localized or can be generalized. So it can be localized or it can be generalized. This edema, other than localized edema, does not become clinically apparent until interstitial volume has increased to 2.5 to 3 liters. So when interstitial fluid becomes abnormal and in excess, then only you can determine generalized edema. There are few words which are very commonly being utilized. One is anasarca. The meaning of anasarca means you get edema involving almost all part of the body, upper limb, lower limb, face, even you can have hydrothorax, hydropericardium, and hydroperitoneum. Ascites is collection of a fluid in a peritoneal cavity. Lipidemia means edema caused by a fluid retained in interstitial space by lipids in the dermis. Lymphedema is edema caused by obstruction to the lymphatic drainage of the tissue. Myxedema is edema resulting from hypothyroidism, and that is we call it a pretibial myxedema, which is ideally not an edema, but it is because of collection of subcutaneous material which infiltrate the dermal tissue and gives rise to what we ideally use the word non-pitting edema. So that will occur in Graves' disease, also in case of mixed edema. Depending upon the organ, if there is an excessive collection of a fluid inside the cerebral hemisphere, we call it as a cerebral edema. Inside the alveoli, intra-alveolar, we call it as a pulmonary edema. In the pleural cavity, we use the word hydrothorax, or we call pleural effusion. In the peritoneal cavity, we call that as ascites, or we call as a hydroperitoneum. And if it is collected in a pericardial sac, we call as a hydropericardium, or we call pericardial effusion. When you see in this multiple area, that is including face, upper limb, lower limb, plus this organ, or we call as a third space, then we call that as generalized edema, or we call anasarca. Basically, this excessive collection of fluid in an extracellular fluid compartment is because of increase in intravascular pressure or because of increased capillary vessel wall permeability or because of decreased intravascular oncotic pressure, or we call osmotic pressure, created by plasma protein, mainly by albumin, maybe because of excessive body fluids, maybe secondary due to lymphatic obstruction, or maybe because of local injury, or because of infection. There is an increased capillary vascular permeability resulting into exudation of fluid, we call exudate, or maybe because of medication which results into sodium and water retention, and there is an excess of sodium in the body resulting into accumulation of fluid. These are all the mechanisms which can end up with excess of collection of fluid in extracellular fluid compartment. We call that as edema. For that simple explanation, this is a pathophysiology which explains you that on an arterial side, the blood flows with a pressure we call as a hydrostatic pressure or arterial hydrostatic pressure that flows through the small arterioles capillary network and then enters into venules. In this particular capillary network, it will be exerting hydrostatic pressure which will try to push the fluid out of the capillary network, and there will be the pressure which will keep the fluid compartment inside the vascular compartment, that will not allow the fluid to go out of vascular compartment into extracellular compartment. That is called as negative pressure created by what we call as osmotic pressure or colloidal osmotic pressure, which is by protein, and main protein is albumin. So difference between these two creates what we call as a net filtration pressure. Net filtration pressure. So with that difference, the fluid will be filtered out. And on the venous side, the hydrostatic pressure is close to zero. Colloidal osmotic pressure is negative. So that extracellular fluid is reabsorbed back into vascular compartment at the venous side. The rest of the fluid which remains in an extracellular fluid compartment is drained away by or reabsorbed into lymphatic capillaries and returned back to circulation. This is what happens in any normal person. So if we take a very simple diagram, that on an arterial side, hydrostatic pressure is say 35, osmotic pressure or colloidal osmotic pressure is 25, so filtration pressure is 10. On venous side, this pressure does not change because protein doesn't come out, so it remains same. Hydrostatic pressure is 10. Say we take a venous pressure to be 10, so the difference is 15. So here filtration is by 10 millimeter and osmotic attraction difference between these two is 15. So by 15 millimeter it is reabsorbed back. So almost whatever is formed is nearly reabsorbed, and this maintains intravascular compartment and extracellular compartment. So you have to keep this thing in mind, that increase in hydrostatic pressure will increase this gradient at arterial end and will increase the filtration. Decrease in oncotic pressure will also increase this filtration pressure and will increase more filtration of a fluid into extracellular compartment, and whatever remaining has to be reabsorbed at the venous capillary. So in venous capillary, if the hydrostatic pressure starts increasing, this osmotic attraction will become less, and when it becomes less, the reabsorption will become less. There will be accumulation of fluid in an extracellular compartment, will result into collection of a fluid, and that will call as edema. And whenever there is an inflammatory damage to the capillary, it will give rise to increased permeability of the capillary that will give rise to exudation of fluid plus protein plus cell will also come out, and that we call as exudate. So exudate will appear in case of inflammation. This is a one chart which shows you formation of edema or collection of extracellular fluid compartment in heart failure, cirrhosis, nephrotic syndrome, etc. Now we know basically in cirrhosis there are multiple factors which are playing a role. We call as a portal venous pressure is increased. There is hypoproteinemia. So two factors are there. Venous pressure is increased. So if you look here in portal hypertension, this venous pressure will be increasing. This venous pressure will increase. So venous hydrostatic pressure will increase. And this osmotic pressure, which is negative, will decrease. So there will be more difference, which will produce less absorption and more filtration. So this pressure will become less and less. So reabsorption will be less, and that will give rise to increased formation of fluid in case of cirrhosis. Plus there are other factors also like increase in aldosterone, which will result into accumulation of sodium and water at the level of kidney in distal convoluted tubule. So sodium and water will be retained. So there will be third factor which will be playing a role in case of cirrhosis of liver. As well as renin-angiotensin cycle will be also actively working, because there will be increased production of renin, and this renin production will increase whenever there is a decreased plasma volume, and that will also give rise to increased production of aldosterone and gives rise to sodium and water retention. So there will be multiple factors which will be playing role in cirrhosis of liver. Also, because of cirrhosis, there is obstruction to the lymphatic drainage, and this will be also one of the factors which will further increase in accumulation of fluid in a peritoneal cavity, resulting into ascites first, then later on you can get edema of lower limb, puffiness of face, etc. While in case of nephrotic syndrome, one of the major factor is loss of protein in urine, which will produce severe hypoproteinemia, which will decrease your colloidal osmotic pressure on an arterial side, and that will result into increase here on this side. So this will reduce. As this reduces, the difference between hydrostatic pressure and osmotic pressure will become more and more, because this gets less. So filtration pressure will increase. Say osmotic pressure reduces to 15. So this will become now 20. So filtration will be more, reabsorption will be less. It will give rise to formation of an extracellular fluid compartment, and that will happen in a case of a nephrotic syndrome. While in a heart failure, there are multiple factors which are playing a role. Because of decreased cardiac output, there is increased renin production, RAS system is acting. There is increased central venous pressure, so that also gives rise to increased venous pressure on the venous side, and that also results into extra formation of extracellular fluid. As well as the person will have primary renal failure that will aggravate the sodium and water retention. All these factors are working together in case of a heart failure. So you might have multiple factors working in a heart failure, multiple factors working in cirrhosis of liver, but in a nephrotic syndrome, the main factor which is working is hypoproteinemia. So if you go through the etiology, where there is increased hydrostatic pressure, so increased hydrostatic pressure will be very common. We'll just go through the main important conditions. That is because of impaired venous return, very classical in case of congestive heart failure, constrictive pericarditis, cirrhosis of liver, venous obstruction, thrombosis, we call deep vein thrombosis. There may be compression of venous system by external mass, and we can call that as chronic venous insufficiency, which results in decreased venous return to heart. In case of arterial dilatation, which will increase your hydrostatic pressure on an arterial side because of extreme exposure to heat or neurohormonal dysregulation. So that will be the mechanism in case of an arterial side. There is another mechanism we call as a sodium retention, which occurs very frequently whenever the person takes an excessive salt intake in presence of AKI or CKD, or there is an increased tubular reabsorption of sodium because of increased aldosterone, we call as a primary hyperaldosteronism or secondary hyperaldosteronism, or there is an increased renin secretion which stimulates the RAS system because of renal hypoperfusion, maybe because of renal artery stenosis or renal artery atherosclerosis, or even in a shock stage. So there is a renal hypoperfusion, renin secretion, RAS system activation, increased aldosterone production, and that gives rise to sodium and water retention. So this will be all the factors which will be there. Inflammation, acute inflammation, classical in case of cellulitis, or maybe a chronic inflammation, or because of angiogenesis, the person will have increased capillary permeability, which will result into exudation of fluid into extracellular fluid, and that will be more of exudates, where water will be filtered out, protein will be filtered out, as well as the cellular infiltration will take place, and that we call as an exudate. If there is reduction in the plasma protein, we call as a hypoproteinemia, which can be because of nephrotic syndrome, or maybe because of chronic liver disease, classical example liver cirrhosis, or because of malnutrition, or because of protein losing gastroenteropathy, or we call malabsorption syndrome. All these conditions results into hypoproteinemia, which reduces the colloidal osmotic pressure, or we call it a colloidal osmotic pressure on an arterial side, and that will increase the filtration pressure, increase more amount of filtration on an arterial side, and decrease reabsorption on the venous side, and that will end up with generalized anasarca. Whatever fluid which is remaining in the extracellular fluid compartment will be reabsorbed by lymphatics. But if there is a lymphatic obstruction because of an inflammation like what we call as a filariasis, or maybe because of neoplastic infiltrations secondary to malignancy, following a surgery like block dissections or post-surgical, or because of irradiation, there is a fibrosis in the subcutaneous tissue, all this will result into lymphatic obstruction, and that will result into what we call as a lymphedema rather than only edema, because it is more accumulation of lymphatic fluid which is rich in lipids, and that will in a later stage will become non-pitting edema. So this will be one of the conditions which will produce non-pitting edema. So if we just go through the major causes: increased hydrostatic pressure, volume expansion will occur in a kidney failure, AKI, CKD, pregnancy, person who is taking long time, NSAID, or because of steroid use, because some of the condition you require to give the steroid in a larger doses for a longer period, almost for lifetime, good number of conditions, they will end up with sodium and water retention. Acute salt load in heart failure, in all this condition, volume expansion, or if there is a venous insufficiency or venous obstruction, say like in case of heart failure, pulmonary hypertension, cirrhosis of liver, deep vein thrombosis, chronic venous stasis. There will be arterial vasodilatation, which will occur very frequently because of calcium channel blocker, particularly we call as nifedipine, amlodipine, etc. Hypoproteinemia in malnutrition, cirrhosis, nephrotic syndrome, GI tract loss, or we call protein losing nephropathy or malabsorption syndrome, and this will be malnutrition, marasmus and Kwashiorkor. Capillary permeability will be abnormal or increased in case of sepsis and cellulitis. Lymphatic obstruction we already mentioned, malignancy, lymph node dissection, infiltration by lymphatics, extrinsic compression of lymphatics, filariasis. In hypothyroidism, it is a mixed edema. It is not ideally edema. It is an infiltration of a subcutaneous tissue by mixed edematous tissue, and that is a non-pitting edema. By and large, increased hydrostatic pressure is classical in case of cardiac, renal, and liver. And in case of a renal acute nephrotic syndrome, or even in case of an acute nephritic syndrome also, you can have a increased hydrostatic pressure. Capillary leakage will be very frequently in cellulitis and sepsis. Also, it can occur in trauma and angioedema. Oncotic pressure reduce is more common in nephrotic syndrome. It is also in case of cirrhosis and in case of malnutrition, and we call as malabsorption syndrome. And we already mentioned capillary leakage, classical in sepsis, anaphylaxis, and even in case of cellulitis. And then comes what we call as a lymphatic obstruction and miscellaneous, that is hypothyroidism, and even in case of Graves' disease. Also, do not forget DVT and chronic venous insufficiency. So now we go to the main part, how you approach to the patient. Always first, from a good history and examination, try to localize the site, whether it is localized or generalized. Localized edema is absolutely rare in case of hypoproteinemia, congestive cardiac failure. Localized edema will be more common with venous, with lymphatic obstructions. It will be usually asymmetrical, unilateral, depending upon which part of the body is involved accordingly, maybe in upper limb, maybe in lower limb. Venous edema, localized, is more common in lower limb as compared to upper limb. Lymphatic obstruction producing localized edema is more common in upper limb as compared to lower limbs. But still, you have to look at the type of edema and where is the edema. While in case of generalized edema, the classical example is hypoproteinemia, and second is in case of a volume overload, classical example is congestive cardiac failure. Then second thing, we always look at pitting or non-pitting edema. So pitting edema is hypoproteinemia, fluid collections, while non-pitting edema is mixed edema, elephantiasis, and lymphatic edema. And whenever there is a collection of a fluid in a thorax, we call hydrothorax, hydroperitoneum, or hydropericardium, it suggests generalized anasarca. It is very, very common in case of hypoproteinemia. And second condition which can end up with similar findings is in case of a severe congestive heart failure. If there is an edema with redness, tenderness, warm, and there is edema, it is more in favor of inflammation, and which is classical example of cellulitis. Always get a good history regarding the symptoms. If person is having pain, fever, there is a localized pain plus there is a fever, it is inflammation, more in favor of cellulitis. If person is having dyspnea, cyanosis, JVP is elevated, liver is enlarged, there is mild ascites, lower limb edema, more in favor of congestive heart failure. If person has got oliguria, hematuria, and there is an edema, it is more in favor of AKI, more in favor of AKI. Person has got jaundice, spider nevi, caput medusa, plus there is pulmonary erythema, etc. It is in favor of cirrhosis of liver, portal hypertension. If person has got mild pallor, shiny skin, loss of hair, there is a skin pigmentation, it will be more in favor of hypoproteinemia. If there is a weight gain, amenorrhea, constipation, bradycardia, non-pitting edema, it will be more in favor of mixed edema. If there is only in upper limb, maybe because of superior vena cava obstruction. If it is unilateral and in upper limb, you must also think in terms of lymphatic obstruction and subclavian vein obstruction. Subclavian vein obstruction, not subclavian artery obstruction. If it is in lower limb, inferior vena cava obstruction, if it is bilateral, and if it is unilateral in lower limb, always think in terms of a lymphatic obstruction, deep vein thrombosis, chronic venous insufficiency, etc. But if a person comes to you with inferior vena cava obstruction, you will have invariably ascites, hepatomegaly, splenomegaly with dilated tortuous vein over thorax as well as abdomen, which are vertical, and the blood flow is from lower to upper. While in case of a superior vena cava obstruction, you will have a puffiness of face, you will have a dilated veins, varicose vein over in upper limb, as well as vein which are running down over the thorax and abdomen. The blood flow will be from above downwards. They will have a hydrothorax, hydropericardium, puffiness of face. Lower limb edema will not be there, ascites will not be there. So these are some of the clues which will help you to find out the site and etiology. So in a history, we always ask duration of edema. We look at the distribution of edema, whether it is in the lower limb, arm, or involving both. It is generalized, it is symmetrical, asymmetrical. We try to find out, is there any signs of inflammation? Is there any symptom signs suggestive of a cardiovascular system involvement like shortness of breath, cyanosis, orthopnea? Is there any ascites, abdominal distension? Is there any symptom signs of hypothyroidism? Then history suggestive of cardiac or pulmonary or liver involvement or kidney involvement. History of drugs, particularly NSAID, steroids, etc. Or if a person is coming from the area where the filariasis is endemic, all this history has to be taken. And then we go for the focused physical examination. We try to find out whether the edema is localized or generalized, pitting, non-pitting, whether there is any signs of inflammation, whether there is any clinical signs of cardiac involvement, whether there is any clinical signs of liver involvement like chronic liver signs, that is pulmonary edema, spider nevi, caput medusa, etc. And then we go for what we call as investigations like blood examination, urine analysis, investigation for cardiac like chest x-ray, ECG, echo, etc. We have already told you, you try to differentiate pitting, non-pitting edema, generalized, localized edema, whether it is exudative, that is exudatives are invariably what we call as inflammatory edema, which are showing you symptom signs of tenderness, redness, warmness, and person will invariably will have fever, while transudate will not have warmness, tenderness, and those we call as a non-inflammatory edema, which is very common in congestive cardiac failure, cirrhosis of liver, AKI, CKD, etc. Severity wise, you try to find out how severe it is, mild, moderate, and severe. Evolution wise, how it had started, it sometimes is very helpful. If it begins with leg, then face, and then ascites, it is more in favor of congestive cardiac failure. If it starts in face, then in lower limb, and then ascites, it is more in favor of nephrotic syndrome. If it starts with ascites, then lower limb, and then face, more in favor of liver, like cirrhosis of liver. And if there is a edema, puffiness of face, and then ascites, it is more in favor of nutritional anemia or nutritional edema like marasmus or Korsakoff. And then examination of urine also gives you idea. Oliguria more in favor of acute renal failure or acute glomerulonephritis, nephritic syndrome. If you get a smoky urine, or we call as a Coca-Cola color, acute glomerulonephritis. If it is a milky white color urine, more in favor of filariasis or chyluria. If a person has got orthopnea or paroxysmal nocturnal dyspnea, more in favor of congestive heart failure, etc. These are all the clinical clues which can help you to identify the causes of edema. We already mentioned jaundice, melena, hematemesis, libido, testicular atrophy, pulmonary erythema, spider nevi, caput medusa, deputerine contractures. All those are signs of chronic liver disease. Constipation, weight gain, cold intolerance, hypothyroidism. Hypertension, ischemic heart disease, valvular heart disease, congenital heart disease, more in favor of heart failure. Vomiting, hiccup, loss of appetite, itching, uremia. Diarrhea, steatorrhea, malabsorption syndrome, etc. There's a big list. You can go through at your leisure time. I mentioned lot of different conditions which can be identified by good clinical examination. So a good history, good physical examination, differentiate between pitting and non-pitting, very very important, non-pitting edema, filariasis, mixed edema. These two comes topmost on the list. While pitting edema is hypoproteinemia, congestive heart failure. These two very frequently classical example of pitting edema. It is immaterial how much is the pitting, or we call severity of pitting, does not identify anything, but massive generalized anasarca is very classical in favor of nephrotic syndrome because it produces severe hypoproteinemia. Non-pitting edema, we already mentioned lymphedema and mixed edema. Localized edema is local inflammation like cellulitis, lymphatic obstruction, deep vein thrombosis, thrombophlebitis, chronic venous insufficiency. While generalized edema, cardiac, hepatic, renal, nephrotic syndrome, acute glomerulonephritis, CKD, you can put idiopathic edema. Angioedema will come in case of localized edema. This is one of the signs of anaphylaxis. So again, same thing is shown in two different ways: generalized heart, liver, kidney and malnutrition, while localized is venous obstruction, lymphatic, secondary due to inflammation, venous obstruction, thrombophlebitis, etc. So these are all the conditions which can produce generalized edema. These are localized edema. Don't forget anaphylaxis. So if there is a pitting edema and if pitting is more than 40 seconds with normal protein level, normal albumin, always suspect venous. If there is an elevated JVP, suspect cardiac. If JVP is normal, suspect venous insufficiency. And if pitting edema is taking less than 40 seconds to come back to normal, very frequently it is hypoproteinemia, and try to rule out the conditions which decreases the protein. One simple thing will help you in your everyday practice. If there is a bilateral edema, very very important, always try to identify non-pitting edema, non-tender, lymphedema. Pitting edema which is tender, pitting edema which is tender, usually it is with low protein state, decreased synthesis, increased loss. Classical example, nephrotic syndrome, malabsorption, etc. And if there is slow pitting, venous hypertension, there is an elevated neck veins, more in favor of what we call as a cardiac, congestive cardiac failure. And if there is no JVP elevated, chronic venous insufficiency. If there is a unilateral lower limb edema, again, non-pitting, non-tender, more in favor of lymphatic obstruction. And if it is pitting, more in favor of deep vein thrombosis, or maybe because of Baker's cyst, or maybe acute cellulitis. Bilateral upper limb edema, always think in terms of, it is bilateral edema, always think in terms of what we call as congestive cardiac failure, where person will have a dyspnea, JVP elevated, hepatomegaly, will have upper limb as well as lower limb, and face also being involved. Pure upper limb bilateral edema, always think in terms of a superior vena cava obstruction. There will be other conditions which can also produce similar conditions like constrictive pericarditis, etc. So always think first, rule out superior vena cava obstruction. Superior vena cava obstruction. This should be ruled out first. And if there is a unilateral upper extremity edema, then always think in terms of what we call as a lymph edema. So try to go through that particular. Unilateral upper limb edema, lymphatic obstruction, unilateral partial obstruction of subclavian vein obstruction, acute cellulitis, and even in case of filariasis, which is invariably tender because it is acute inflammation. This will produce acute inflammation. But in case of bilateral, always suspect superior vena cava obstruction, more common. Hypoproteinemia we have already discussed. You must think in three conditions: nephrotic syndrome, cirrhosis of liver, and GI tract disorders, where you will have a diarrhea, here you will have a massive proteinuria, and here you will have an abnormal LFT. So normal protein, always think in terms of a cardiovascular condition, very common. And if there is a petechia and there is a fever, think in terms of sepsis. And if there is a local accumulation, always think in terms of a local inflammation. This is one very important slide which you should try to understand very well, because we come across three common conditions: cardiac, liver, and renal. In cardiac, dyspnea is very common, which is more of exertional. You can have orthopnea or PND. So if anyone who comes to you with an edema with SOB, shortness of breath, that is dyspnea, orthopnea or PND, straightforward it goes in favor of cardiac. And invariably you will have a JVP elevated, S3 gallop, you will have a abnormal increase in the size of the heart, producing cardiomegaly, liver enlarged, etc. And past history of hypertension, ischemic heart disease, valvular heart disease, or congenital heart disease. While in case of a liver, it is first starts with ascites, that is abdominal distension, then lower limb edema. Very rarely person will have a orthopnea, absolutely rare. The most common cause of cirrhosis of liver is alcohol and hepatitis. So past history of jaundice and chronic alcohol intake will be the common history available. And on clinical examination, jaundice, what we call is a spider angiomas, pulmonary erythema, we call hepatic flaps or asterexis, deputrine contractures, then caput medusa, etc. If you get all this finding, it is more in favor of liver disorders. While in case of kidney, the person will have a severely, what we call is a generalized anasarca, urinary symptoms more in favor of oliguria, hematuria, frothy urine, etc. And person will start with facial edema, periorbital edema, hypertension, and person invariably will show you, urinary examination will show you gross abnormality, and that will be suggestive of renal. So dependent edema is more common with cardiac. It will start more with cardiac. Facial will be less common. Ascites will be less common. Hypoproteinemia will not be there. So proteinuria will not be there. In hepatic, you will have a more of dependent edema. Ascites will be there. So ascites will be there and dependent edema will be there. And you will have a mild hypoproteinemia. and urine will be normal, while in case of renal, you will have a dependent edema, facial edema, ascites will be mild, there will be severe hypoproteinemia, and person will have a proteinuria. And when proteinuria is massive, the person can have a severe generalized anasarca. So, renal edema will spread from the face to lower extremity, while cardiac edema will spread from lower extremity to upper extremity. Cardiac edema will be more pronounced in the evening, while this will be, renal will be more in the early morning. You will have a pallor, while here you will have a cyanosis. Skin over the edematous area will be warm in renal, while in case of a cardiac, usually it will be cold because of decreased perfusion. Very important things in case of a left heart failure, you will have a fatigue, exhaustion dyspnea, orthopnea and PND with basal crackles, S3 gallop, while in case of a right heart failure, you will have a dyspnea, fatigue, anorexia. You will have a raised JVP which will not be seen in a pure left ventricular failure. You will have a dependent edema which will not be a characteristic in case of a left heart failure. While basal crackles which are there in a left heart failure which you will not see in case of a right heart failure. You will have ascites, pitting edema, raised JVP, pleural effusion, hepatomegaly, etc. But by and large we come across what we call as a congestive heart failure, which is left heart failure with right heart failure. So all these findings are together. So always, very frequently you will come across with basal crackles and JVP elevated, ascites, hepatomegaly together. We call that as congestive heart failure. So already we have mentioned all these things before. This also we have covered up. This is what we call as typical chronic venous insufficiency. You can see the skin color changes. You call pigmentation. This will suggest chronic venous insufficiency. If you come across a woman who is under the age of 50 and mild edema, always suspect one of the possibilities idiopathic edema, which is a cyclical edema, very frequently seen in female under the age of 50. If you come across a painful edema, one of the conditions which you will see in your everyday practice good number of time is a deep vein thrombosis, which will be very frequently unilateral, and you will have a severe calf muscle tenderness, and you have to go for a Wells score. And there is another condition which produces a painful swelling is reflex sympathetic dystrophy, or we call as a chronic pain syndrome. It is a chronic regional pain syndrome. So remember that there is one condition where secondary to the chronic painful conditions, person develops chronic regional painful syndrome, CRPS, and that produces reflex sympathetic dystrophy, and that can have a painful swell and which will be unilateral. This is again, in this you will get a dystrophy very frequently. You can see this is red, this will be tender, and there will be reflex sympathetic dystrophy. This is localized swelling, redness, warmness, tender. Very frequently you will see in case of cellulitis. You can see a varicose vein. This will also produce on the side of the varicose vein a venous edema. We call as edema because of chronic venous insufficiency. And secondary to that chronic venous insufficiency, person will develop venous stasis dermatitis, changes in the skin, and then later on venous ulcer. This is varicose vein, and person can develop ulcer also. This is inflammation. You can say there is a blister also. This is severe cellulitis. This is Baker cyst, which has ruptured, and that will produce swelling, and that will be localized swelling on the posterior side of the popliteal fossa, very frequently on a popliteal fossa area. We call Baker cyst rupture. See this swelling here, and which can be also seen in an X-ray. So that is Baker cyst. there is one sign called the steamer signs. This is very useful to find out the edema in the subcutaneous tissue. So in a normal person, you can easily pinch the skin over the second toe. So we call that is negative. But if you can't pinch, then we call the steamer signs is positive. And this indicates subcutaneous edema. And this is very frequently in case of a non-pitting edema. So it is also called Kaposi steamer signs. And this is a sign of lymphedema. So if you can't pinch the skin at the base of second toe, then it is called as a steamer signs or Kaposi steamer signs, which suggests that there is a subcutaneous non-pitting edema, and that is in favor of lymphatic edema. So these are the two good picture which you can see. This is unilateral lymphatic edema. This is again, you can see there is a skin changes which are taking place, and this is hyperkeratosis which can occur. This is lymphatic edema secondary to filariasis. This will become non-pitting edema. You can see this will be non-pitting edema. This is congenital disorders of lymphatic drainage. This we can skip over. We have already discussed what are the difference between heart failure, renal, etc. At your leisure time you can go through. Yes. One word regarding idiopathic edema. It is very common in young women, usually obese. There is no cardiac etiology, hepatic or renal etiology. There is a periodic episode of edema unrelated to menstrual cycle. It is along with abdominal distension. Exact etiology or pathophysiology is not known. There is some capillary leak. Whether diuretic induced or not, it is again a question mark. So low sodium diet and stop diuretic may give you good results. Once a person who comes to you with an edema, and clinically if you are suspecting cardiac, go for X-ray chest, echocardiography, and in case of a liver disorders, abdominal ultrasound. And also in case of a renal disorder, abdominal ultrasound is a must. To rule out renal disorders, 24-hour urinary protein is very, very important. And in case of a liver disorders, liver function test with liver enzymes, serum albumin and INR becomes important. And paracentesis to find out the type of fluid in case of ascites will be helpful. This is a slide which shows you if there is an acute edema which is less than 72 hours, whether unilateral or bilateral. If it is bilateral, very rare. Bilateral DVT is very rare. Inferior vena cava clot, still very, very rare. Unilateral edema is more common. It will be very common in DVT. You will have to use a Wells score, and you will have to look for D-dimer studies, etc. Another condition which can give rise to acute edema is anaphylaxis, sepsis, and don't forget DVT. Subacute, always look for pitting, non-pitting. If it is pitting, look for heart failure, kidney failure, cirrhosis, chronic venous stasis. If there is no hypoproteinemia, or if there is a hypoproteinemia, you work out accordingly, because hypoproteinemia will be more common in cirrhosis and liver disorders. And if the protein level is normal, you can go for cardiac checkup and you can go for chronic venous insufficiency. And if it is non-pitting, it is more in favor of lymphedema or in case of hypothyroidism. Or also sometimes you see that pretibial non-pitting edema even in case of what we call as a Graves' disease. These are all the different slides. At your leisure time you can go through. These are all the different slides which we have discussed before. This is a differential diagnosis of edema. We got flow charts. If it is unilateral edema, this is algorithm for leg edema. Then this is common causes. Then this is systemic evaluation. This is unilateral edema if it is there, how you approach. This is chronic unilateral edema, etc. As far as the treatment is concerned, you have to find out the basic etiology and treatment of basic etiology. In case of cardiac, diuretic will be one of the drug of indications. In case of hypoproteinemia, say in case of nephrotic syndrome, and in case of cirrhosis of liver, malnutrition, and malabsorption syndrome, GI tract protein losing nephropathy, protein replacement is a must. But if it is a GI tract, protein oral replacement will be of no use. In case of DVT, anticoagulation and surgical intervention will be necessary. In case of congestive heart failure, liver, kidney, drug-induced salt excess and sodium retention, you will require salt restriction. So, in case of an acute conditions where you recognize the red flag sign and person is having severe decompensation, you will require ABC, we call as a maintenance of airway, breathing and circulation. This will happen very frequently in case of cardiovascular conditions. In case of generalized edema, fluid management will be very, very important, because already some of the time the person is volume overload. In case of localized edema, symptomatic treatment, antibiotic, surgical drainage, particularly in case of cellulitis, abscess, etc. In case of congestive cardiac failure, fluid restriction, diuretic therapy, inotropic supports. In case of renal failure, protein intake restriction, manage complication and treat the underlying cause. In nephrotic syndrome, steroid may be absolutely necessary. You must also look for the side effect of steroid, manage complications, and you must educate the person. In nephritic syndrome, fluid restriction is absolutely necessary, antihypertension, including diuretic therapy, and treat the underlying cause. In case of a CKD, fluid and electrolyte management is absolutely necessary, antihypertensive treatment, and treat the underlying cause. These are roughly the highlights how you treat them. So, general measures: treat the primary condition, bed rest, sodium restriction, diuretic, almost quite common in good number of conditions. Special measure, we already told you: fluid removal, centesis, paracentesis, plasma volume expansion. You can give albumin in case of cirrhosis and nephrotic syndrome. Insertion of a shunts in case of cirrhosis. Pharmacological treatment in case of heart failure, vasodilators. Angiotensin converting enzyme inhibitor, vasoconstrictors in case of cirrhosis of liver. In heart failure and nephrotic syndrome, you might require a continuous arteriovenous hemofiltration, etc. This will be necessary in case of rare conditions. In a fast recovering pitting edema, you will require what we call as treatment of malnutrition, treatment of malabsorption, treatment of cirrhosis of liver, and treatment of protein loss. In case of a slow recovering pitting edema where protein is normal, you will require treatment of congestive heart failure, chronic venous insufficiency, and what we call as a DVT. These are the three conditions. As far as the lymphedema is concerned, diuretic, elevation, exercise, compressive, elastic stocking, massage, etc. And if there is a chronic infection, you might require a treatment of dermatophytes, then treatment, antibiotics, etc. in case of cellulitis. In lymphedema, you might require flavonoids, liposuction, and coumadin is utilized to stimulate the subcutaneous macrophages and local proteolysis. Complications of edema and ascites: very frequently person will have a peripheral edema which can end up with cellulitis because of little less movements, venous thrombosis. You can have a impaired visual loss from periorbital edema. Because of secondary cellulitis, you can have a pain, cosmetic purpose, unacceptable. You can have a scrotal and penile edema, which can result into damage to the local organs, local tissue, limitation of physical activity, pleural effusion, etc. Now, key takeaway point, peripheral edema is caused by either excessive intravascular hydrostatic pressure or decreased intravascular oncotic pressure or increased capillary permeability or impaired lymphatic drainage. The most common etiology is DVT as far as acute edema is concerned and cellulitis in acute edema, which is usually unilateral, where medication side effects is usually bilateral. More common etiology, chronic bilateral edema like heart failure, kidney, liver and chronic venous stasis you should look for. Lymphedema and hypothyroidism are non-pitting edema. Routine assessment of acute unilateral edema should be focused primarily on DVT by Wells score, and also you should not forget what we call as a cellulitis. Routine assessment of a chronic bilateral edema should include JVP examination, measurement of albumin and urinary albumin examination. So I end my lecture here. I thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. This lecture is mainly for educative purpose. This will help you a lot in your everyday practice. Go through your at leisure time. It will help you a lot. Whenever you see a patient of edema, you must identify the exact etiology. Good number of time it is not edema, and treatment what is being given like diuretics etc. is the wrong treatment, and you can end up with lot of complications like electrolyte imbalance, dehydration etc. So do keep this thing in mind. So I end my lecture here. I hope this will be very helpful to you.